Today, I'm Muhammad Moin. I'm going to show you a very interesting case in which we have, as you can see, this is a patient who has iris bombay due to formation of posterior synecdoche, and he's got a secluso pupillae, and he is pseudophakic, and you can see two sutures on the side. I'm showing the slit lamp, and you can see the iris bowing forward. There's a PCIOL in the back, and there seems to be mild posterior capsular thickening in this case. I think there are multiple findings in this case. When you go to the periphery, you can see this, the width of the angle is less than 1/4 of the cornea. So that's according to Van Herrick. It is a very shallow anterior chamber, and you can see this is a perfluorocarbon fluid liquid over here, a bubble of perfluorocarbon you can see floating over here, and I'll stop the video in between and show you that perfluorocarbon. So now we're seeing multiple things in this patient. What surgery has he had? Let's guess. And this is the perfluorocarbon you see, and we're trying to look at the retina of this patient as well now and see what do we see inside. And we see the optic disc is there, and the retina seems to have a sheen on it, which is signifying that he's got a silicone oil inside his eye. So he has underwent pars plana vitrectomy, and after that the eye is siliconized, but I think they used perfluorocarbon. Now the patient is looking down, and you can see the meniscus of the silicone oil inferiorly. You can clearly see that meniscus of silicone oil over here. This is the meniscus which you see over here. It's very important to find that out, and that tells you about the patient has got an 80% fill of the silicone oil. And hey, I'll just show you again that area of perfluorocarbon when I get the chance to show you that. This is very important to see. If I just show you over here, this is perfluorocarbon. You have to watch out and look for the area over here. And in between, I'll show in the video that he's got a superior emulsified silicone oil as well. So you've got both things. So the patient was referred to me today for the evaluation for glaucoma, and seeing this, and he's got posterior synecdoche formation along with the formation of iris bombay, which I'm going to demonstrate as well. Here you can see this is the superior hypereolean or emulsified silicone oil, which rises up, while a perfluorocarbon liquid, heavy liquid, is going to be floating down over here. In order to remove that superior silicone oil, you need to go and remove it from the anterior chamber, probably during surgery. It will come just beneath the endothelium. It's easy to remove. With that perfluorocarbon, somebody need to have the patient sitting up and then go from inferiorly with a needle, and you need to aspirate that, and that is sometimes very tricky to get rid of. And that's why when you're doing perfluorocarbon exchange, you need to be very careful to remove that perfluorocarbon all the way out. Here you can see, now you can see easily that bubble of perfluorocarbon, and it's going to stay there inferiorly over there. Long term, it can cause a bit of corneal endothelial decompensation over there in these cases. And now I'm going to show you the iris bombay. When you make that slit, you can see there's 360 synecdoche formation, and there's formation of that iris bombay. If you look over here, the iris is bowing forward like this over here, and similarly it's much easier to see over here. So this is bowing forward, and he's got a posterior synecdoche all the way up. So you need to do a YAG iridotomy anywhere supranasal, supratemporally, and that is going to flatten the iris. This patient had intraocular pressure of 30 because of that, and that developed because he had uveitis. He has had initial vitrectomy, and then he had cataract surgery and silicone oil exchange before the emulsified oil. And here you can see in the periphery as well, there is shallowing of the anterior chamber. So if you see a patient like this in your exam or anywhere in your clinical exam, when you're seeing patients, this becomes a very tricky and a challenging case to diagnose. So his diagnosis would be pseudophakia. He would have a perfluorocarbon liquid with secondary glaucoma. He's got emulsified oil. He's got siliconized eyeball with peripheral laser mark. So there's multiple diagnoses in these patients, and the way you would manage this patient is immediately do a Jaeger-odotomy, get that intraocular pressure down, resolve that virus Bombay, and then if the retina is flat, then you would go in and remove flat with laser and or cryomarks. So the adequate adhesion 360 barrage laser, you would remove that oil and you would remove that perfluorocarbon from the anterior chamber and the emulsified oil. The glaucoma can sometimes remain long-term a permanent entity in these patients. So thank you very much for watching, and please do subscribe to our channel and click the like button. Thank you.